Good morning and welcome to the Editor's Podcast for the Journal of the Academy of Nutrition and Dietetics. I'm Dr. Linda Snetselaar, Editor-in-Chief of the journal. This podcast today focuses on an article in the journal titled Systematic Review of Content Validity and Meta-Analysis of Predictive Validity for Clinical Outcomes Associated with Malnutrition, identified by the Academy of Nutrition and Dietetics and the American Society for Parenteral and Enteral Nutrition Indicators of Malnutrition. And with me, I have two doctors today, Dr. Charlene Compher, who is Professor of Nutrition Science, Director of Nutrition Graduate Programs in the Department of Biobehavioral Health Sciences in Penn Nursing at the University of Pennsylvania. And also Dr. Alison Steiber, who is the Chief Science Officer at the Academy of Nutrition and Dietetics. Thank you so much for being with us today and welcome. So to enhance the article that you published, I want to welcome your thoughts on some of the questions that are focused on the AAIM tool and hospitalizations. And I want to add a little bit of background to this. So this particular article focuses on the Academy of Nutrition and Dietetics and the American Society for Parenteral and Enteral Nutrition Indicators of Malnutrition, or the AAIM tool. And this particular tool uses nutrition assessment parameters to diagnose patients with malnutrition. The systematic review that both of you participated in writing was designed to evaluate the content validity of the AAIM approach relative to the Subjective Global Assessment, or SGA, or Patient-Generated Subjective Global Assessment, PGSGA, and to determine whether malnutrition diagnosed by AAIM at or near hospital admission is associated with increased mortality, length of stay, hospitalization cost, or readmissions. So my first question is, what were some of the past barriers to the design of an instrument like AAIM?
Sure, I'm happy to get started. So Linda, thank you so much for inviting us to this podcast. I'm very excited to participate. Malnutrition diagnosis across the settings, whether you're in a hospital, in a dialysis center, in an outpatient cancer center, any of these areas has long been fraught because there's no gold standard for malnutrition diagnosis. We do not have a biomarker or an X-ray that can give us, yes, you have malnutrition, no, you do not. And because of this, we have a very varied amount of different tools, some that have been very thoroughly validated, some that have not. Many have been validated in one or two particular populations, but very few have been validated across the board. And these are mostly composite tools where they take multiple parameters. In the case of the AAIM tool, we have 6 parameters, but in other tools, SGA has 7 categories. There's also multiple versions of subjective global assessment. You mentioned the PGSGA, but there's also 5-point SGAs. Detsky first validated or came up with a 3-point scale. We have, in Sweden, they use a 5-point scale, and in dialysis, they tend to use a 7-point scale. So not only do we have a variety of a plethora of tools, but we have, even within one category of tool, we have variable versions. This causes a lot of confusion. So practitioners are out there using a variety of tools depending on setting and population. And most of these tools contain components of them that relate to physical examination. And historically, within the United States in particular, dietitians were not trained to conduct physical examination. Or we only had a small pool of dietitians that were trained to conduct physical examination, most of them in nutrition support. And so when we came out with the 2012 consensus paper, where we asked people to use this one tool, had 6 parameters, 3 of which were really asking people to do a nutrition-focused physical exam type of assessment, we had a lot of problems because our dietitians were not trained to do that, and that the message was very inconsistent.
Thanks for that introduction, Alison. And also let me echo your thanks to Linda for inviting us to this podcast. I think sometimes in our country, we focus on individual issues and individual clinical insight. And that results in people having difficulty talking with each other. When I think about the AIM tool and what it has brought with the standardization of language and standardization of details, is that within my health system, dietitians are able to talk to each other. They're able to hand off the patient to someone else who can see where they are, where they've been. They're able to inform medical providers about the specific factors that indicate malnutrition. So because of the standardization of language, it's very helpful with workflow, but also with educating physicians. And I think we need to just value that. I'm also hoping that language standardization will empower us to identify much more clearly what is the prevalence of malnutrition in any given setting, because we need to know that, and we also need to know what we can do about it. How can we treat it? How can we prevent it? So AIM is empowering, I think.
Thank you so much. Excellent details. And I too believe that this is such an important tool, particularly in this very important area. So my second question is, what are 3 of the basic findings that are important from this systematic review that you did?
I think the 3 most important findings, the 3 clearest findings, are that we had 9 studies where investigators had compared the AIM approach to SGA or PGSGA concurrently at hospital admission. And this included more than 2,000 patients. The results were almost 90% sensitivity, that you're identifying malnutrition appropriately almost 90% of the time, which is really impressive. The specificity was 84%, so we're not missing too many who don't have malnutrition. Mortality was consistently increased. Hospital mortality during the hospital stay, twofold in a group of more than 6,500 patients reported on. That's a really rigorous outcome. And readmissions were increased twofold. Hospital length of stay was increased 5 days, but the readmissions, the mortality, and the content validity relative to the SGA, I think were really quite strong findings. So we know that the AIM is accurate at diagnosing malnutrition, but also we know that it predicts negative outcomes. These are patients we need to focus on.
Yeah, I guess I just want to drill home the 2 points of this, that because we don't have a gold standard that is a bioindicator, the best we can do is what Charlene has just described, which is to have content validity, where we're comparing it with another similar tool, and combine that with predictive validity. We have done without a gold standard about as much as we can do in terms of validating this particular diagnostic tool.
Fantastic. Very, very impressive data and superb rationale for the work that you did. So my next question is, how has the Academy's work helped to drive the design and writing of this particular systematic review?
Well, I have to give enormous credit and kudos to Dr. Compher. She and her team did an outstanding job. They came forward with the idea for the project and, really was the leader in making this happen. And so the Academy supported, and I supported Dr. Compher, but she was really the driver behind this.
Well, let me add that my skills as looking at evidence came from the Academy's Evidence Analysis Library training program back in the day. That's where I first got interested in these topics. And but I have gone on to lead clinical guidelines at ASPEN for a number of years. This was an important project to me because we just needed to know that we could trust AIM. And that probably sounds naive or dumb, but I wanted solid ground beneath my feet. And I think we got that. But for me personally, I also had the pleasure of working with very experienced people like Alison and Gordon Jensen and Ainsley Malone, and mentoring two younger dietitians in my hospital who hadn't done anything quite like this before, but were more than willing to put in the time and effort and have said that they learned so much from the process. So I think it was successful on a lot of different levels, satisfying on different levels.
Mm-hmm. Thank you. Thank you both so much. And I think your shout out to the Evidence Analysis Library, which has been a marvelous cornerstone, I think, for the Academy is wonderful. And thank you all for the work that I know has to go into something like this. My next question sort of builds on this. What is the general process in terms of developing a systematic review like this one?
I'll start. First, you have to assemble a panel of qualified people. And I really resonate with people with mixed professional backgrounds because I think we bring different perspectives to the table. So this panel had two very experienced dietitians, a physician. We had a professional librarian who did all of the literature searches. And we had two young new graduate dietitians within their first 3 years of practice and a former student of mine. So you get the right team together. You get a librarian to help you with the search terms. We searched 4 different databases, and each of those databases had specific requirements for the search terms that could be used. And then when we got the results with something like 650 articles, we loaded them into Covidence, which is a systematic review software platform. Covidence will sort out the duplicates. And so then you can start the process of evaluating whether these articles meet your inclusion criteria. We included everything published in English since 2012 when AIM was published. If they had SGA and AIM collected at the same time in hospitalized adults, or if they had AIM and they reported on the clinical outcomes that we were interested in. We excluded papers if they compared to something else other than the SGA or PGSGA. And we did not get additional information from authors. We wanted everything we were relying on to be available to other readers if they chose to check.
I would just add, if it's okay, just a few comments about this. What I think makes this paper as strong as it is that it was well grounded in really well formulated PICO questions. And so we thought a lot about what the population, the intervention, if there was one, or comparator, the outcomes. I think the other thing that made this paper quite strong is that because we were doing a very narrow slice, we were really just looking at the AIM tool and its validity. We had more homogeneity with the data sets. And so we were able to answer the big questions about mortality. You need a fair amount of strength and power and homogeneity in the data to be able to do that. And I think this paper does it really, really well. And that's a powerful thing to be able to say that we have predictive validity with mortality. The prospective cohort that we've recently completed, we didn't have the power to be able to do that because mortality, thankfully, is fairly infrequent. And so, it really takes a systematic review like this to be able to show those kind of hard outputs.
And I would like to say that we see this particular article as a wonderful model of how you should do a systematic review. And I hope that others, as they're writing systematic reviews, will indeed use it as a starting point in terms of the way you should do a systematic review. So thank you so much. And then my next question, how can AIM be used to further research by RDNs and hospital patients?
Dietitians working with hospitalized patients in the US are sitting on a massive trove of data in their electronic medical records. If they can take charge of that data and consistently use the AIM tool to identify malnutrition, then we can know what is the prevalence of malnutrition. Is it different in university teaching hospitals than it is in community hospitals? Is it different in hospitals with a burn center than others? We can actually also find out, this is something we didn't see, with repeated measures of malnutrition. When we see someone who's malnourished, we initiate a treatment and then we reevaluate. And we know that some people were at nutrition risk, but they were not malnourished. And then during the course of the hospital stay, due to the clinical sequelae of disease, they become malnourished. We need to know more about those transitions. And dietitians are the ones who generate these data. They have every right to own these data and to describe that for us. And I also think that, theoretically, someone could set up a clinical trial testing treatment modalities. Is it different if you give someone who's at nutrition risk an oral nutrition supplement at the door of the hospital than if you don't? Those kind of projects are really needed, and I think they are in the wheelhouse of clinical dietitians. And that's not to mention the ones who work in extended care facilities, nursing homes. There's just so much to do. Rehab centers.
Absolutely. I would just kind of build on that statement. So, I think the two areas that for me are very unknown and need to be addressed. One is across settings. So while I think now we can put a pin in AIM for the hospital setting, I think what we don't know are other settings, other populations outside of the hospital. And I also think we have a lot of work to do in the pediatric population. And so I think those are two things to think about: expanding the settings, expanding populations. But more to the point for what Dr. Compher was saying about interventions. I think what we haven't shown is if we have an effective intervention, will we see change? over time or due to the intervention with this tool? Is it sensitive to change? How long does it take to see change? What parameters are most sensitive to the change, or is it the tool itself? So I think resolution of diagnosis is a big area for the future that needs to be addressed.
Alison, you just completed a lovely randomized clinical trial that's published in American Journal of Clinical Nutrition. I can plug it. Do you have any thoughts about the number of variables that need to be considered in using the AIM tool in hospitalized patients?
Thank you. That's very appropriate. We can both plug each other because Dr. Compher wrote a great editorial for that article for us. I will say that, when we went into doing that prospective cohort, what we really asked the question is, do we need all 6 parameters? So right now, we hear from physicians, and I think, Charlene, you would say you hear it a lot from European physicians, that it's too much, it's too complicated, and it's too difficult to do. Now, as a person with a doctorate in human nutrition, I would like to answer that, well, nutrition is complex. It is difficult. However, we did take a very close look at this. And so when we did the predictive validity for the AIM tool, we did it both with all 6 parameters, and we controlled for number of sites, we controlled for disease severity, we controlled for body mass index, we controlled for age and gender. So we had a fairly robust multivariate model. And within that, we had statistically significant productivity or predictive validity for our outcomes. But interestingly, when we removed edema and hand grip strength, it did not change the predictive validity. And so the reality is, at least within a hospital setting, the 4 parameters versus the 6 parameters has equal levels of predictive validity, at least within our study.
And I think that when we looked at the SGA versus AIM, the one variable that was 4 of the 9 studies included all 6 variables, but there were 5 others that did not include hand grip strength. For various reasons. Some said, well, critically ill patients just can't do it. They're sedated, you can't use that parameter. So I think it's reassuring that we're seeing, I always count on having at least 2 pieces of research to make me think maybe I need to shift my clinical practice a little bit. And I think we've got that now.
Thank you. And then my last question is, why is the AIM tool important to the work of RDNs working in hospital settings?
I have no doubt that it's extremely valuable. I think it gives RDNs working in hospital settings data-driven conversations to have with other members of the healthcare team in a consistent way. And that has huge value. For one thing, practically speaking, to the degree that the dietitian is communicating these kind of details to the provider who's going to do the discharge assessment, he's much more likely to identify and code that malnutrition will be coded appropriately, which has been a long-standing problem. But there are ways now to integrate the dietitian's work and identification of this information that takes some time, that providers say they don't have and probably don't have, and that's really in our wheelhouse to do.
Absolutely. I would add on to that, from a perspective of payment, we have been challenged because the Office of Inspector Generals have a variety of inspectors using a variety of ways of determining whether we have quality. So some are perhaps still using serum albumin, some are perhaps using the GLIM framework, some are using SGA, some are using the AAIM tool. And so if you have a variety of criteria and we're not all on the same page, then when a registered dietitian goes and uses subjective global assessment that perhaps has been shown to be valid in that population, the inspector may not understand the literature, may not understand that that is a valid tool to be used. Whereas now I think we have two really big, powerful studies that are coming out almost simultaneously that are saying AAIM is valid. It has content validity, it has predictive validity. Let's all get on the same page. If you just want to use 4 variables, that's great. And then we need to train the CMS folks and the people at the Office of the Inspector General so that when dietitians are practicing and doing appropriate diagnoses, they are being able to be, correctly coded for that.
Mm-hmm. Very good point, Alison. I also think when I think about RDNs working in hospital settings, I mean, most of us want to have a life beyond the hospital setting. We want a vacation here and there. We want some time away. We want to go to a conference. And all of those are situations where you need the other members of your team to pick up where you left off, because you needing a break doesn't mean you don't want your patients to be taken care of. So to the degree that we can use consistent language and consistent identification of these variables, it eases that process incredibly.
Superb comments. And basically what I'm taking away from this is this evidence-based tool can be incredibly important as we're doing multidisciplinary collaborations and putting the RDN in the center of those collaborations is incredibly important. So thank you so much, both of you, for doing a marvelous job of telling us more about this particular article, but particularly focusing on that critically important tool, AAIM. And I know that those RDNs who are listening to this particular podcast will learn a great deal from what you have been telling us today. And I think it's also an inspiration to them to become more involved in multidisciplinary teams. So thank you both so much for responding to my questions and for taking the time to do the podcast today. Thank you.
Thank you, Linda, for inviting us. It's been a pleasure.
Absolutely. Thank you so much.